Hi, it's Tom here from Running Physio. Today I want to talk to you about medial tibial stress fractures and 5 key tips that are going to help you with diagnosis and management. I've also put a link in the details there for you to our webinar series. We've got lots of free webinars available for you, including one on iliotibial band syndrome, Achilles tendinopathy, and also lower back pain in athletes. So do check those out. They're free. You can access them via the link and learn loads more about the assessment and management of running injuries. So let's talk a little bit about medial tibial stress fractures. They are easy to miss. On the whole, actually, stress fractures are very easy to miss and take an average of about 3 months to be diagnosed. So we do need to have a suspicion of them, particularly in running athletes and also military recruits. And some, particularly the higher grade and higher risk stress fractures, actually will need a more specific management approach. They may need a period of non-weight bearing potentially, particularly those high-risk stress fractures. So it's important that we're able to identify them and modify our management accordingly. Also, bone stress injuries seem to be a bit different from our other injuries we see in runners, like tendinopathy, for example. In bone stress injuries, they don't tend to do so well continuing to run with pain. So we need to try and identify these bone stress injuries early, and we often need a slightly different approach with them to get good results. Now, first up then on these 5 top tips is a finding from a recent paper from Milgram et al. In military recruits. And our first top tip is that with a medial tibial stress fracture, the pain on palpation is typically going to be less than 10 centimeters. Now, this is important because it helps us to differentiate from medial tibial stress syndrome. And this is something we've thought for a while. Stress fractures tend to have more sort of focal pain points, and this appears to be supported by this recent research. The majority of people in that study that were found to have a medial tibial stress fracture actually had a smaller area of pain, typically around 1 to 3 centimeters. And no people in this study had a pain that spread over more than 10 centimeters and actually had a medial tibial stress fracture. So first, simple tip: if you're going to palpate the posterior medial tibia and you're finding a smaller region of pain, less than 10 centimeters, it should lead you towards a medial tibial stress fracture as a possibility. If it's more than 10 centimeters, you've got more widespread symptoms, that's more typical of your medial tibial stress syndrome, which is thought to be more of a bony stress reaction, not actually progressing all the way to a true stress fracture. Also, whilst we're talking palpation, if you have someone who has anterior tibial symptoms and they've got a focal tender spot in the anterior tibial region, I would be suspicious of an anterior tibial stress fracture, and these are considered high risk. So if you suspect an anterior tibial stress fracture, actually it is appropriate to arrange urgent imaging. You may go for an urgent x-ray because that can help rule out a true fracture, but really what we want is an MRI. They're considered a gold standard for bone stress injuries. So if it's anterior and you've got those other signs and symptoms of a stress fracture, it is appropriate to push for urgent investigation. If it's more medial, they found in Milgram et al.'s work that actually you don't necessarily need to rush people off for imaging with a medial tibial stress fracture because it's considered low risk and it can often be managed with simple rest and things that we're going to talk about shortly. Okay, so tip 1, small region of pain on palpation, less than 10 centimeters, more consistent with a medial tibial stress fracture. Larger than 10 centimeters, more consistent with medial tibial stress syndrome. Point 2 here is, again, another simple test we can do. The HOP test was found to be highly sensitive in Milgram et al.'s work. They reported a sensitivity of 100% for the HOP test when we have someone with a medial tibial stress fracture. Now, my understanding is that what this means is if you have a negative HOP test, if you can hop without pain, it means it's pretty unlikely that they have a medial tibial stress fracture. Now, the specificity wasn't so good. I believe it was around 45%. So what that means is, in my understanding at least, is that hopping doesn't necessarily tell you, yes, definitely this is a stress fracture, because Think about lots of other pathologies that are going to have pain with hopping, tendinopathy, muscle pain, joint pain. You're going to get quite a few false positives potentially. So the hop test might be quite good for ruling things out. If it's negative, it might help us rule out a medial tibial stress fracture. But if it's positive, there's still potentially other diagnoses, other reasons why they might be getting that pain. So second point, use the hop test, and if it's negative, it may help rule out a medial tibial stress fracture. If it's positive, you still need to hunt a little bit more to confirm that diagnosis. You'd still want that focal pain on palpation. You'd still want to do your other tests of range of movement, palpating tendons, etc., to try and narrow down that sort of diagnostic accuracy, if you like. Also, other features of bone stress injury, so pain with walking, night pain, any swelling or bruising, those would also wave a flag to make you think this is looking more like a stress fracture potentially. Okay. So simple point 2, hop test actually really quite useful here. Now what they found to be less useful in diagnosing stress fractures was the fulcrum test. Now the fulcrum test involves supporting the tibia proximally and distally and trying to use your knee as a fulcrum to put a kind of bending force through the tibia. Now, just thinking about that makes my tibia hurt a bit. I think it doesn't sound like a particularly nice test to do. And I would imagine this is going to be painful for people even without pathology in many cases. So this is not a test we recommend. It's not particularly useful in ruling in or ruling out a tibial stress fracture. So I would focus more on the palpation, the hop tests, and other signs and symptoms if you're looking at diagnosis. Okay, so point 3 then in our 5 simple tips here is that particularly in the acute phase of managing a medial tibial stress fracture, rest is actually best. Now, this is not something that I encourage very often for people. I like to try and modify activity where possible, but if you have a tibial stress fracture, you do really need a period of rest to let that settle. Now, that can be quite a short period of rest, and in Milgram et al.'s study, just 10 to 14 days was used, and this was found to be pretty effective in lower grade bone stress fractures like grade 1, and about half of the grade 2s also had a good recovery of symptoms with just 10 to 14 days of rest. But it's less effective when you're looking at the grade 3, grade 4 options. You're going to need to go for longer periods there. Now, if we have a little bit of a look at what Milgram et al. Have recommended in their rest protocol post-medial tibial stress fracture, if you've got a grade 1, and this is in their study was based on bone scan findings, they're recommending a simple 1 week rest from painful activity, from impact, etc. If it's a grade 2, 2 weeks. If it's a more serious grade 3, you may need 4 weeks, and a grade 4 stress fracture in this study, they recommended up to 6 weeks rest. Now, it's important with this that we don't use these as very sort of rigid rules. We do need to be guided by symptoms with this. And this is a study of male military recruits, so we can't necessarily apply that to all the populations that we see. I think perhaps a bit more realistic in the runners, which of course the population I'm interested in, would be Fredriksson et al.'s recommendations. Now this, if I remember correctly, is based more on MRI findings. A little bit of a dated study now, back in 1995, but they say for grade 1 bone stress fractures, you're looking at 2 to 3 weeks of rest from running. For grade 2, 4 to 6 weeks of rest from running, grade 3, 6 to 9 weeks, and for the more serious grade 4, they would put them in a cast for 6 weeks and then go on to 6 weeks of rest afterwards. So I think this is probably a little bit more realistic. If you're looking at returning people successfully to running, I think you will often need a slightly longer rest period. So point 3, rest is actually going to be best in this acute phase to settle things down, rest from impact, rest from painful activity to allow things to settle. But the plan is that that's going to facilitate a return to sport. So we're going to rest to let things recover, but then we've got a plan to get people back when they're able to do so. Now, for a lot of athletes, they'll be able to cross-train in that period. So you might be looking at things like using the bike, cross-training in the pool. They'll often tolerate gym work as well, but again, you've got to pick it depending on the patient. So rest doesn't mean complete inactivity. We can keep them fit with cross-training and other activities, but it will often involve cutting down impact and painful load-bearing activities until things settle. Okay, so there's point 3. Rest is best in the acute phase. Point 4 is when you're looking to return, I would aim for a pain-free approach to reloading. Now, this is where bone stress injuries do seem to be quite different from, say, tendinopathy or joint pain, where we know actually we can work with some mild symptoms providing they settle quickly. In my experience, and also in some of the research, this doesn't seem to work particularly well with bone stress injuries. If you keep working in pain, it just seems to take a lot longer to get them back to where they want to be. And I think this is particularly true in the acute and subacute phases. It becomes a little bit less clear if you're working with someone who's had a prolonged history of shin pain. Perhaps you're looking at more of a chronic medial tibial stress syndrome, and we've got to a point where that connection between what pathology might be there and the pain that might be there is less clear. Perhaps there are other things feeding into that if they've had those symptoms for a longer time. In those chronic cases, I may be more prepared to load them with some discomfort, providing you're getting some progress over time. So it's thinking about the appropriate stage. In the acute stage, when there's still some bony healing going on, I would tend to aim for pain-free with your reloading. And I would often start by doing some simple impact work like jogging on the spot, progressing on to jumping in place and bounding, and then onto hopping, and then start a gradual reintroduction of running. If they've been quite irritable in symptoms, I might include walk breaks initially and gradually build up that running based on symptoms to get them back to their goals. And it does seem that the intensity of the training seems to be quite important in bone stress injuries, according to some recent research. So often we build that training volume first, and then we gradually ramp up the intensity when they're ready. So point 4, aim for a pain-free reloading process with these medial tibial stress fractures at the appropriate stage of their healing after they've had some rest to allow things to recover, and gradually build up the volume first, then the intensity. Now, final point, point 5 here, is that I really think with stress fractures, we do need to think about the bigger picture. Now, I was interested in the study by Milgram et al. It seemed really simple, just have a couple of weeks rest and then get back into training. And they seem to get good results, at least in the short term, but the study doesn't really talk about long-term results or recurrence. And we know actually people can get recurrent shin pain. It can be a real persistent issue for them. And we know too that stress fractures are related to lots of other things that are going on in our life. So sleep seems to be an important factor for bone stress injuries. And earlier work by Milgram et al. Supports this, showing that lack of sleep may be key in the development of bone stress injuries. So think about that bigger picture. Think about sleep, think about stress, think about what's driving their training. Because if someone is developing a stress fracture, it can actually be because they're driving their training beyond what they can cope with. So we might want to look at, why are they doing that? Do they have a healthy relationship with their sport? We might want to think about nutrition, things like calcium, vitamin D, and energy availability. These are all important things in bone health. And of course, this bigger picture stuff we talk about in a lot more detail in Running Repairs Online, where we've got a whole module devoted to bone stress injuries. But I really think about those bigger pictures with your patients of the having stress fractures, particularly if they've had repeated stress fractures. Think about sleep and nutrition, think about training, think about some of those psychosocial factors that drive training, and think about their rehab needs too in terms of strength. Can they be stronger through that lower limb and have those muscles managing some of the load? So perhaps there's a little bit less stress on bony tissue. So final point 5, I think we do need to think about the bigger picture, consider those other things that are going to influence this person, their general health and their bone health, and make sure that we address them as we get people back into their sport. Because otherwise, if we've not really addressed nutrition or sleep or recovery or the training and how it progresses, you will often find they'll come back to you with another bone stress injury or a secondary injury somewhere else. And we really don't want that for our runners. We want to get them back and keep them back. Okay, so let's just whiz through and summarize those five key tips for medial tibial stress fractures. So number one was you're likely to see pain on palpation of that posterior medial tibia of less than 10 centimeters in a medial tibial stress fracture. Number two is you're going to expect a positive hop test, so pain with a hop test, and that is thought to be a highly sensitive test, although perhaps not massively specific. Number three, rest is actually going to be best in the acute phase, and how much rest we need is going to be guided by the severity of the bone stress injury. So grade 1 to 2, you may get away with as little as a couple of weeks, but also it's going to be guided by their symptoms. Then number four, aim for pain-free reloading. As we bring them back in, gradually build, but try and keep it as comfortable as possible. And then final point that we've talked about here, see the bigger picture with bone stress injuries, not just the medial tibial stress fractures, but stress fractures in general. Think about sleep, diet and nutrition, training, behavior, psychosocial factors, etc. Because we need to address those to get people back and keep them back in their sport. Okay, thank you very much everyone for listening today. I look forward to your questions and comments in the replies afterwards. Do check out those free webinars that we've got available for you. You can learn loads from them, and I look forward to speaking to you again very soon. Bye for now.